research and scholarly colloquium that is a shared experience in your intensive with the PhD and DNP students. So we see both groups represented here. And I would like to welcome you, those of you who are new, to the first one, and those of you who are returning. It's great to see your faces. I see a number of DNP students here who are in their last semester, and you have that look, so that's great. Everybody's looking forward to May, and it will be here before long. I wanted to introduce our first speaker this morning, and that's Dr. Flo Weierbach. Most of you have had her in class. She teaches in both PhD and DNP programs, and she is here to share with you this morning her experiences and her research with her grant from the American Nurses Foundation. And I would like to share with you, because she probably will not, that it's a very prestigious award. Nurses across the country make application for this award, and they give one nationally. So Dr. Weierbach's work was recognized in a very prestigious way, and we're very lucky to have her with us on the faculty. And from now, I will introduce Dr. Weierbach, and she'll talk with you about determinants of health for rural caregivers. Dr. Weierbach.
I want to say that you guys are all really fortunate. This is the first time I've presented on the findings. So know that you guys are hearing stuff that no one else has heard before other than what's been done in conversation. So no formal presentation has been done on this. You guys all are the first group. And, you know, I was excited when Dr. Raymond and Dr. Edwards asked me to do this, and I thought, who's more appropriate to hear it first than you guys? Because the majority of you in the room have heard about this grant. Who in the room have I not had yet, or am having for the first time? Okay, you're the only ones that have not heard about this model. Everyone else has heard about this model, including the undergraduate students that I have now with the honors and discipline. So, you know, you're thinking, oh my gosh, I have to hear about this model one more time. Now you get to hear about whether or not it worked. So that's an exciting place to be. So what I'm going to do today is I'm going to talk about some of the processes and the findings around the grant. I'm not going to tell you about the introduction, because I think we all, that to me isn't what's the most important thing. You know, what's more important is what is an introduction, and what does the purpose of an introduction serve for the rest of the paper and for the rest of the grant. And you know, the introduction really sets the stage. The introduction should have that punch statement to it. It should have the statement that grabs everyone's attention. It's like the first sentence in a novel. It grabs everyone's attention, and it makes you want to go on. So that's what I want you to think about in regards to the introduction. You know, usually an introduction includes epidemiological information. It includes statistics. It's boring. How do we make that come alive? You know, how I made that come alive when I submitted my grant for A&F was to say that caregivers died. That's how I grabbed attention. I grabbed attention with the fact that caregivers die, and I also grabbed attention with no one knows about it. Because we don't have good statistics around the amount of deaths. A lot of it's experiential. Raise your hand if you've ever done home health or hospice. Raise your hand. I know some of you have. Okay, those of you guys that have done home health or hospice, what's the call you hate? You hate the call from the daughter that says that dad, who's taking care of mom, just ended up in the hospital, don't you? You have to figure out what to do with mom, because dad's not able to anymore. That's what I'm talking about. And that's how I grabbed your attention. And when I was writing the grant, I was talking with my mentor at the time, who's not at this university, wonderful nurse researcher, acute care focused. And I said to her, I said, you know, caregivers die. And she's like, no, they don't. I'm like, yeah, they do. She had no concept of it. It was outside of her realm of thinking because she had not done that type of practice before. versus those of us that have spent time in the homes, we know exactly what happens. So really think about your introduction, what type of information is available. When I was writing it, she really felt strongly that we needed to include that, that caregivers die. We didn't know how to include it. So we did it through a personal communication mechanism with APA to bring that home. So if you have a phenomenon of interest that maybe isn't clearly documented, and the epidemiological information may not clearly be there, think about how else you can do it. Yesterday with the PhDs, we were talking about changes in skin color with wound care. And I happened to be involved with one of the first people that was looking at changes in skin color. And he did it experientially. That's how he first brought that attention. So, think of it as a case study type of approach. So, the other thing we always tell you about is what's the pertinent literature. And you need to look at the pertinent literature to determine what we're going to do, right? Isn't that what we all tell you? What does the literature tell us? And the literature should guide whatever we're doing. I know that's what I tell you. Don't look at me like I've never said that before. That's what I tell you to do. Well, what I found in the pertinent literature related to caregiver health is it was about Alzheimer's disease. I'm dealing with elderly, so it was about Alzheimer's disease. And it was about maybe congestive heart failure. And it was maybe about arthritis. And it was maybe about cancer. I'm a nurse. I'm concerned about nursing factors. I'm not, okay, the medical stuff is important. I'm not saying it's not. And disease processes are important. But I'm concerned about nursing. And again, I knew that when I was in the home doing home health, what kept me in the home was one of two things. What the person could or could not do, usually looking at ADLs and IADLs. And the other thing that kept me in the home was someone's ability to care for them and their knowledge base. That's what kept me in the home. Now, you guys that have done it, think about it. Is that what's kept you in the home? We like to say, oh no, what's kept us in the home is the medical diagnosis. The medical diagnosis qualified us to be in the home. So when I was looking at the literature, what I kept on finding was Alzheimer's disease processes. I didn't find very much about ADLs and IADLs. The other thing I found in the literature is that it's all about stress. These caregivers are stressed out the yin-yang. And we're not going to talk about anything else other than stress. Maybe we'll talk a little bit about health promotion. But when we talk about health promotion, we talk about did they follow the screening advice? Did they get their flu shot on time? Did they get their pneumonia shot? We never talked about why they did it. We never talked about what their physiological changes in health were, and we never talked about a broad view of health. So I really framed my literature review around what was known, building the argument that we don't know what contributes to health because we've never looked at health. We've never looked at health very broadly. And you know what? They bought it. They liked it. And I was awarded the grant. So I wrote this in a different place, and then I came here, and I was like, oh my gosh, I got to do this now. And that was challenging, and I'm going to talk about that a little bit more. But I couldn't have done it without student help. So many students helped me with the project. Many of you heard about the project, which was just helpful in and of itself because he encouraged me to continue to look at it. But the students that helped, and I don't think anyone's in the room today that helped, was three PhD students, Robin Foreman, who is now, if you think you're never going to get there, who is now in her dissertation phase. And she helped on, you're thinking, if you know Robin, she's interested in civility, and what does that have to do with caregiver health? Not very much. But Robin joined me early for residency hours to look at recruitment. So she helped me with recruitment. She identified where we could recruit. She went with me when I recruited, when I presented. and learned the process of how to recruit. The other thing that Robin was able to do was she was able to connect me, because connections become really important. She was able to connect me with a religious group that I had no contact to. So that was something else that Robin was able to do, and I think she would say that it was a worthwhile experience. The other student that helped me was Christy Miller. And here again, if you're thinking you're never going to get to this point, you will. Christy's currently in qualifying exams, and Christy was my tuition scholar, and she also did some residency hours with me. She did the bulk of the data entry. She didn't do all of it, but she did, I would say, probably 80% of the data entry for the instruments. Great help. She also did some recruitment, but she was really an instrumental person to make this work. And the skill she learned by doing that was how to organize a research study. What does it mean? How important it is to enter the data accurately. So that was something that she got out of it by both being the tuition scholar and also doing the residency hours with me. The other student was Evelyn Brewer, and she's also a PhD student, and I think she's finishing up her coursework right now and her residency hours. And Evelyn was a beautiful addition to the study. Those of you that know Evelyn can appreciate that. I open my mouth, you can tell I'm not from this area. You look at my last name, I don't have a last name that brings me to the area. Evelyn has all of that. She is from up near Boone, North Carolina. She is really in tune to the Appalachian culture. She was able to make connections in a way differently than I could. And when you look at those of you that have had the summer course that I teach, the rural and vulnerable, and you look at trust in the rural population, she had that trust. She was an insider. I was an outsider. I would always be an outsider. But she brought that to the table, and she really helped with the recruitment. And here again, this was somewhat of her area of interest because she was interested in rural Appalachia, but she wasn't real interested in caregivers. But she was interested in what does it look like, how do you do it with recruitment. So Christy was a wonderful addition. The other three students that I have were borrowed students from the Center for Nursing Research, and I cannot speak highly enough of all three of them. Caroline Miller and Amanda Crawford are both undergraduate students, student workers, and Dr. Edwards made them available to me when Christy wasn't available, and they did some of the scut work. I don't know how else to say that, but that's what they did. The beautiful thing that Caroline did is that she took all of the instruments, 3 different time periods, collated them all together, put them all together, organized the study once everything was in. Huge time saver for me. Amanda copied things for me. And when we were doing analysis, Rafi got Shaheen Zaire, who was the GA for the Center for Nursing Research, to run some numbers. So wonderful help from students. So if you're thinking, how can a project that I have no interest in have any meaning for me, and how can I get something out of it? Look at what is the skill that you want to learn. Don't only look at what is the content, because it's the skill that you learn. You know, all of them learned a different skill, and for Caroline and Amanda, who are undergraduates, it was a wonderful way to look at how they can be involved in a project and still have meaning. So I definitely say to look at that. So to go into the study a little bit more, the overall purpose of the study was to examine the determinants of health status for caregivers living in a rural area. And I had 2 specific aims. One was to identify which of the factors are significant determinants of health at 3 time points. And I looked at baseline 8 weeks and 16 weeks in my literature guide at my time periods. And then the other one was to examine how the determinants of caregiving and health status of caregivers change over time, because we know it changes, we know people die, but we don't know how. So those were the overall purpose and aims. And the model, how many of you guys have seen this model? Raise your hand if you've seen this model before. Everyone's hands should be up except for the people I currently have that did not have me before, because you guys have all seen this. I know you have. Health is the dependent variable in the middle, caregiver health. And then we have caregiver needs, caregiver tasks, health promotion behaviors, and beliefs and attitudes of caregivers. I created the model. The literature allowed me to create the model and what I was looking at, and then what I set out to do was to test the model. So when I looked at the model, I had to determine what was health. Now, you've already heard me talk about disease and how I don't like disease, right? So I looked at health through the World Health Organization definition, a very global look at health that is more than the absence of disease. So then the challenge was, how do I find an instrument that measures this? And historically, the SF-36 is what measures health. And the person I was working with at the time said, you can't use the SF-36 flow. You got to use something else. So the PROMIS instruments had just come out from NIH, and they were doing work with it where I was at the time. And they said, use the global health. And I looked at it and it made sense, so I used that. I still don't think a lot of people are using that. I know that Stacy's using the global health. I know that Dr. Rasmussen is using some of the PROMIS instruments. But on the whole, we're not using them a lot. They're free. You don't have to ask permission to use them because they're developed by the NIH. So if you're wondering, either for information as an independent variable or as a dependent variable, how you can find an instrument, you might want to look at the NIH PROMIS instruments because they're out there, they're free, we know they're valid, we know they're reliable. So that was beautiful for me that I was able to be steered in that direction. So then I had to look at attitudes and beliefs. And we all know that we do caregiving, or we do what we do for different reasons. So the attitudes and beliefs was really kind of like my cultural proxy. And then I had to go find something to measure it. And I was fortunate at the time that I was working with someone who had developed an instrument looking at attitudes and beliefs in the Alzheimer's population. So I looked at that instrument and I decided to pick out the things that were most pertinent for me. So I looked at the concepts that were most pertinent to me, and the ones that I chose, I did not choose the entire instrument because it did not all make sense. He was dealing with Alzheimer's. I wanted to deal with it more broadly than that. I looked at family relationships and affection for the elder. How do we feel about each other? Are we obligated to care? What are our values? And what are our attitudes regarding spirituality? Really felt that would capture it. And I was in a European, I was in an area of the country at the time that really had a heavy European influence. I still think it would be applicable to a different population. I really thought that the attitudes and beliefs, that nothing was going to come of it. I just had to put it in there. I felt strongly about it, but the literature wasn't supporting it. I didn't think anything would happen with it, so you're going to hear what happened with it in a minute. Then looking at tasks. Everyone was talking about tasks because task goes into stress. So the task one was easy, looked at one that had been used a lot. It was looking at it was looking at demand and difficulty. Task was the easiest one. Then looking at needs. Oh my gosh. Can you imagine the amount of needs that a caregiver has? I had a little bit of difficulty finding something that could measure needs. Finally happened upon a dissertation that was done in the late 80s, early 90s, that was looking at home care needs for hospice patients, closest I could come. So I said, okay, I guess that's what we're going to use. Wrote to the author. She gave me permission. She gave me how to score it. Tell you more about that later. And off we went with needs. The easiest one was health promotion. We like health promotion as nurses, right? That was the easiest one. I went with Pender's Lifestyle Health Promotion Profile 2. Valid, reliable, tested on everyone. It didn't matter. I was solid. Then I had to look at the time periods. Pick the time periods based on what the literature said of when health changes occurred, and added another time period to see if it was earlier. And you'll hear about those results too. Went with 3 time periods because we really didn't know. So the study design is a descriptive longitudinal design with 3 time periods, 5 instruments. You can see where they are. I've talked about them already. And off we went. Moved to Tennessee, got notice that I got funded, and said to both Dr. Edwards and Dr. Raymond, like, oh no, what do I do now? You know, and they just encouraged me to plow ahead. I applied for a Center for Nursing Research grant and also an RDC small grant and got awarded both of them. Applied for IRB, got it. Didn't have any trouble, minimal difficulty with IRB, minimal difficulty getting the other grants. And then I needed to recruit. Like I said, I don't sound like you guys. I don't look like you guys. I don't have a name like you guys. And thankfully, I had been in Virginia before and had done some statewide things and had some connections with the area agencies on aging. And I was able to take those relationships and build on them. So the key I want you to hear is about relationships. And I gained entry into the organization that Chrissy Mullins is working with, which is Mountain Empire Area Agency on Aging, and their PACE program. Because they, in Virginia, there were always 2 agencies that were held up in Virginia as the pillar agencies of aging. And the one was up in the Charlottesville area, and I had worked with them, so that was a positive for me when I went to the others. And the other one was Mountain Empire, that their previous executive director was doing wonderful things. Who would ever think of a rural PACE program? Usually when you talked about rural PACE programs, what you heard was that it didn't work. And the executive director up at Mountain Empire said, what do you mean it doesn't work? I'm going to make it work. And Chrissy, where are you? I know I saw you come in. Does it work, Chrissy? Yeah, it works. And not only does it work, but Appalachian Area Agency on Aging also has a PACE program. I don't know if any of you guys have been there. Have you been there, Chrissy? They also have a PACE program. They were the first places I recruited from, were those 2 places, and it was because of the relationships I had from Virginia, I'd only been gone from Virginia for a year, that I was able to recruit from them. And they were wonderful to work with. I talked with all the CNAs up at Mountain Empire, and lo and behold, I got my first participant, because you know the first participant and the last participant in any study are the most important ones. I got my first participant in March, the beginning of March, about 6 months. And people were like, how did you do that? That was really fast, given all the limitations I had with recruitment. Now, after that, it took a little bit more time and a little more energy to get more participants because, because my geographic area was so huge. I was able to get participants here in the Tri-City area after I relaxed some of my criteria looking at rural and went with, do you think you're in a rural area? Never really was able to break into North Carolina, even though I tried multiple different times to get in there. They were just really, really difficult. The take-home message here is make sure that you have access to the people that you think you have access to. I have better access now than I did then. But like I said, this was written in a different area, and access in that area was different, and I had a different strategy. But you got to make it work. So after I got my folks and I had everything set, I needed to look at how am I going to record their information. What am I going to do with them? So we had to do a database. The previous person that was in Rafi's position created the database for me. Very user-friendly, very clear in regards to how to do it. More importantly, though, we had to do some data management. Now, I have 3 time periods and 5 instances, and I'm going to ask the person to fill out the same thing at 3 different time periods. And these people don't have money. So we set up a 1-800 number so people could call in, so it wouldn't cost them anything. I did stamped self-addressed envelopes. I did color coding, so all of my time 1 was yellow, all of my time 2 was green and all of my time 3 was blue. So as soon as I saw those colors, I knew which one it was. Then I was dealing with different areas within this large geographic area, and I wanted to be able to know quickly where someone came from. And if I just go 1, 2, 3, 4, 5, I have no idea where they come from. So I created schema to be able to quickly identify where they come from by the state. So if I got a TN, I knew it was from Tennessee. If I got a VA, I knew it was from Virginia. If I got an NC, I knew it was from North Carolina. So that was the first thing I would see is VA1, VA2, TN2, TN3. Then I also wanted to know a little bit more. I wanted to know what county or what political jurisdiction they came from. So I added the county or the city name abbreviation to it also, so that I could quickly say if the PACE directors up at Mountain Empire would say, well, what does it look like up here in regards to what our needs are? I could quickly pull everything from Southwest Virginia and say, this is what it is. So that was why I looked at that scheming area. So after we got all the data in, we needed to look at the data and we needed to clean the data. And cleaning the data sounds much easier than what it is. But when you clean the data, you need to make sure it's all there. You need to look and see how much is missing, because unfortunately, not everyone completes everything. Things get missed. People think it's not important. So you have to clean the data. Did that with the assistance of Rafi and the Center for Nursing Research. Then we needed to create the stuff that we really needed. So, we had all these questions, all these items, but we couldn't look at each item individually. We had to look at the items from what they meant. So we had to look at how the items get grouped together to look at the factors and the concepts, factors and concepts using interchangeably, how they go together to measure it. So when we talked about health promotion, one of the health promotion items was nutrition. Well, I didn't look at each nutrition item individually. I looked at nutrition collectively. So how to do that, and that was an interesting endeavor. Have to follow directions to be able to do that. Just know that it's out there. I think that lots of times when we first look at instruments, we get really overwhelmed and we have no idea what we're looking at. I know that was the case for me, probably the case for many people, and you just have to look at it and figure out, now, what is it that they're really telling me? Not what is each individual question asked, but what is it collectively that it asks. So did that. Needed to look at the demographic variables, what was important to know about each individual, and then at the end with the data management, after we got everything in, we needed to look at are they valid and reliable. Looked at the literature based on the instruments, looked at my results, everything came out really high. So I know that all my instruments were good for the population I was looking at. Looking at the recruitment and retention a little bit more, the 3 ways I did it was word of mouth. You heard me talk about using and having Robin and Evelyn help me with that. Healthcare and elder care providers, you heard me talk about Mountain Empire helping with that, the area agencies on aging. Some healthcare providers, on the whole, healthcare providers did not help with this. The elder care providers helped more. My biggest bang for recruitment was through the newspaper. I was getting really frustrated, couldn't get anyone after I got that first one. And finally was able to get an article in the newspaper. Johnson City Press interviewed me. I knew it was going to be coming out over the weekend. It came out Saturday morning. By like 8:30 in the morning, I had hits on my email. And within a week's time, I doubled my referrals. It was like, oh my gosh, what happened here? So thinking about how you can use the media, how you can get your word out, helps. Retention was not so much of a problem. So if I could get the people, they stayed. I recruited 90 people, and out of the 90, 75 completed time 1, low attrition rate. And overall, if they completed time 1, they completed time 3. So out of the 75 that completed time 1, 62 of them completed time 3, and that's what we ended up analyzing. There's still a lot of work that can be done in regards to analyzing the data, in regards to the participants in recruitment, in regards to what was the best method. I've not done very much with that. So anyone who would like to do that, that's there. These are my participants. You can see pretty much along with national in regards to the male and female participants, what they're doing, looking at ADLs and IADLs. If you look at the length of time that they've been caregiving, some long time periods out there. There was one individual couple that was caring for the sister of one of them that had a congenital abnormality. So some long time periods. And you can also see that they had some problems in regards to chronic health conditions themselves on self-report. So to get into the fun stuff, the specific aim 1 was to identify which factor were determinants of health at specific time points. And I used multiple regression with this. And I'm going to skip through that to come right here, and I'm going to go through each slide really quickly. Looking at the attitudes and beliefs and the health promotion, what became important here was family values, spirituality, and spiritual growth. Stress management did too. Now remember I said before that I didn't think that anything was going to happen with attitudes and beliefs, and lo and behold they did. They were significant. Really surprised me. I was like, oh, is this really right? So went on to looking at tasks and needs, and the first look at tasks, nothing came out. Nothing came out as significant. A second look at it, some stuff did come out in regards to significant with tasks in regards to demands. But still, not what I was expecting to find. So you never know what you're going to find with research. Personal time became important, and so did how do I deal with life and how do I deal with what happens, which was a little bit more in line with what the literature was saying. So looking at specific aim 1, what we saw were changes in general physical and mental health, and we also saw that there were intrinsic versus extrinsic factors that contributed to health. And the literature previous to this, and what I've seen, is saying that it's extrinsic factors. It's what we do for someone, not where they're at. So knowing that where they're at really makes you have to think about, how am I going to do this as a nurse? How am I going to change my practice? Does practice need to be changed? And then the other thing that came out really, really strong was the spiritual components and spiritual growth. I really was not expecting that, and I'm still not sure what that means, and I'm going to be doing a follow-up study looking at that in more depth. So my second specific aim was to examine how the determinants of caregiving health change over time. And for this, because of the way the literature was, we used non-parametric tests. We used Friedman's test to look and see were there changes, and then Wilcoxon to see where the changes occurred at which time period. And the findings here, I also think are interesting, because the findings here show that yes, there are changes in general health. And there are changes in general health at time 1 to time 2. There are negative changes at time 2 to time 3, and there are changes again that are negative from time 1 to time 3, so health is getting worse. When we look at physical health, though, when people die, you usually think of physical health, not mental health, right? Unless if it's suicide. And I said before, people die, and that's why we're concerned. That's what led me to this whole thing. It was not physical health that changed, but mental health did. So with mental health, there was negative changes at both time 1 to time 2, time 2 to time 3, not time 2, and then overall there were changes. So these were important things to look at in regards to when changes in health occurred. Looking at where was it and how where did the changes and what contributed to those changes, you can see I pulled them out, and the ones that really had the most when we look at health promotion was stress management. Okay, so the literature, we already know that, right? When you look a little bit more, when you look at tasks, these burden scale ones or the task ones, not shown too much. But when you come down to the attitudes and beliefs, oh my gosh, look at what happens when we look at family relationships and how we value family relationships. So, you know, do we always take care of people because we want to? Yeah. Is it always good that we take care of people because we want to? No. So, you know, when you're in the hospital or when you're in the clinic and you're trying to get someone to do something that they don't want to do, you might want to think about what does that mean to their health. And is the care recipient really going to benefit if they're doing something that they don't want to do? Looking at needs. We need to have people have time to rest. We need to have people to know what to expect. I don't know that we are still doing a great job with those two areas. And the needs I looked at individually. So looking at what overall that meant for specific aim 2, here again, you're really looking at where were your changes and your determinants, and they were some within your health promotion, some within your attitudes and beliefs, and some within your needs. Really looking at intrinsic factors, factors that we as healthcare providers cannot do. We know that the most difficult thing to change is the way someone views something. That's more of an intrinsic factor. And how do we do that? How do we provide information? How do we provide rest? Has anyone ever scheduled CNAs for the home? Anyone ever had that type of job? Thankfully, I never did. But usually they get, what, 4 hours a day, right? Do we ever do it on Wednesday night? Why would Wednesday night maybe be important based on this study? Spiritual needs, what happens on Wednesday night in the Bible Belt? You go to church, right? Okay, do we ever schedule for Sunday morning? No. So are we really meeting the needs of the caregiver? No. So, you know, those are some of the things that we need to be thinking about, and also thinking about how do we provide rest. Respite tends to be the big hot item. Everyone thinks if you throw some hours at them, they're going to be okay. They may or may not. So what were the limitations of my study, other than the fact that I have like 4 minutes left? Limitations, at times I felt like I was locked behind something. I couldn't access the people. I didn't know the people. They didn't know me. The instruments were not all tried on this population. The attitudes and beliefs had not been tried on a general elderly caregiver population. The needs was about cancer needs. Some of those questions were really bizarre. I couldn't take them out. They were asking about kids and how the kids got help. I couldn't take that out. I had to include it. I had to look at disease entity instruments when I was looking at nursing entity items of interest for me. So that was really a limitation of the study looking at that. A limitation of the study is to say I didn't get the full participant number. I wanted to get 150, I got 90. Life happens. And then, you know, and you move on. So know that there's going to be limitations. The fact that I am in an area of the country that's extremely homogeneous is another limitation. That's something that people would say, even though it's a quantitative study, to be concerned about. So how about what are my nursing implications? We need to look at how changes occur. There's still not a good feel for how there's a change in physical health. It would be interesting to do a physiologically based study at the same time with a perception study to see are there changes. Usually when we look at physical health, we're looking at inflammatory processes as beginners with stress. So looking at it that way would be helpful. Looking at what really is the impact with mental health on stress. I don't think that we understand that really well yet. physicist or someone who deals with physiology out there that's willing to do that. I don't want to do that. But I want to know what happens because of it. Because I want to be able to say that when we see X, similar to when we see a hemoglobin A1C of 10, what are we going to do? We're going to make some changes, right? We know that there's going to be some problems coming down the road. I would like to know that there's some type of biomarker out there that when we see that number, we know we need to make some changes. It's not there yet. We're not there yet in regards to how to look at health physiologically. Recruiting caregivers. Found out a lot about recruiting caregivers. About a third of these folks did not want to get paid. And it's not because they didn't trust me. It's because they just wanted to be able to have a voice. That's what they wanted. Looking at how do we view health in the caregiver population? How do we study it? You know, we study it through a disease entity because we're told to do it that way. But I think that a lot of what the caregiver does is not based on the disease, it transcends the disease. To be able to give a medication transcends the type of disease. To be able to give someone a bath transcends the type of disease. So think about that. And then looking at the positive impact on health was really spirituality, and the negative impact was really looking at family values. So where are we going from here? Well, lo and behold, Dr. Edwards, Dr. Stidham, and I have gotten the invitation to write a grant to look at non-professional caregivers. So we're going to be working on this grant using this model, looking at can we extend the model from a family caregiver into a non-professional caregiver, someone who gets paid though. So that's kind of exciting to be able to extend the model into something else. Looking at non-elder caregivers. You know, if any of you guys are looking at caregivers but are not looking at the elderly population, I think that it upholds the determinants are strong regardless of the care recipient population. You'd have to use different instruments. If I was dealing with a child, caregiver of a child, I probably would not be using a home care needs assessment. Or I wouldn't be using the Alzheimer's burden scale. But the determinants are there, looking at how that can occur. And I've had some early conversations with some people about that. And then also looking at extending it to another region of the country. I've had some conversations about that. The next study, in addition to the one that Dr. Edwards, Dr. Stidham, and I will be submitting for, is continuing to explore the spirituality piece. And hopefully I'll be doing that in the next year or so. So you're thinking, okay, am I going to continue to hear about this in class? Yeah, you are. I hate to tell you guys that, so just know that you're going to continue to hear about it. We continue to work with the data. If you're a PhD student, probably. If you're a DNP student and want to work with it and look at interventions based off of it, there's material here that we can pull from. The sky's the limit in regards to what you guys can do with it. I have lots of data. There's lots of different opportunities to look at this data. There's the ability to look at the relationship between more than one determinant. There's the ability to look at how only one determinant contributes to health, how there's changes over time. There's the whole piece of the recruitment that I've not explored yet. And there's a whole qualitative study because it was amazing when I enrolled these people what they told me that needs to be explored. So you're thinking, oh yeah, this is a quantitative study, I want to do a qualitative study. It's still there, it still needs to be done. And I think, one of the things to think about is that whenever we do a study, we just look at the specific aims and we don't do anything else with it. But there's so much more that we can do with it. So I really appreciate ANF taking a chance on me. And allowing me to have 2 extensions, which was painful, but they allowed it, and I think that it was worthwhile for them to do that. ETSU, both the Center for Nursing Research and also the Research Development Committee also took a chance on me. All of the caregivers, I look forward to be able to getting something out in press in regards to what the findings are, because I couldn't have done it without them. The First Tennessee Area Agency on Aging and Disability really helped with recruitment and championing it. And then where I wrote the grant was the University of Nebraska Medical Center, and I wrote it under the direction of my mentor at the time and a previous faculty member from this school, Dr. Carol Pullen, who's not here anymore, but I was auditing a grant course, and the objective was that you had to write a grant. It's like, okay, well, I guess I can write a grant. Who am I going to write a grant to? Well, I guess I'll write it to A&F. And lo and behold, I wrote it to A&F under her direction and my mentor's direction, Dr. Bernice Yates, and it got funded. So, look at your opportunities. That's the take home. Look at your opportunities. Look at what people are telling you. Believe in your faculty. Believe in your mentors, because we see strengths in you that you may not see. And if you just give us half a chance, I gave both Dr. Carol Pullen and Dr. Bernice Yates half a chance, and it came out positive. So believe in your faculty. We really do have your best interests at heart.